Okay, next on our program, we get to the actual work of GaPQC that we've been doing over the last probably more than a year. We'll recap now. And you'll hear about that from our maternal chair, Dr. Melissa Kottke, and our neonatal co-chair, Dr. Ravi Patel. But I get to introduce them now. So Dr. Kottke is a professor in the Department of Gynecology and Obstetrics at Emory. She completed her fellowship in complex family planning. I didn't know that. And is the medical director of the Teen Services and Family Planning Clinic at Grady. She's director of the Jane Fonda Center at Emory, which is involved in research and program development focused on adolescent sexual and reproductive health. She also serves as a medical consultant for the state of Georgia's Family Planning Program and the maternal co-chair for the GaPQC. Current areas of her research include dual protection, over-the-counter contraception, and ways to improve sexual health for teens. She's now going to give us an update on the maternal initiatives.
Hi, y'all. I'm also emotional about this topic, so I'll try to keep it. No, I'm better. I'm all better. Do you have slides for me up there, Michael? Oh, wait, I'm in charge. I see. Green button. They're like, yes, you can see them. They're right there. We started this morning reviewing the vision and mission, but here they are printed out for you on a beautiful slide. My normal first slide is some disclosures. So I would like to disclose that, again, Lisa Ely is responsible for these slides and making these slides. I'd like also to acknowledge the maternal health EPI team, Dr. Christina Pham, Liz Burkhart, and Linda Tran, who also helped put a lot of this data together to share with you today. So thank you very much. As y'all know, we are, GaPQC has been on the maternal arm has been utilizing AIM bundles for several years now, and I'm going to report just super high level and briefly because we only have a little bit of time on the 3 AIM initiatives that we have done. We're incredibly proud, referencing our first CDC grant, we had a goal of having 10 hospitals participate in the early part of the years. And now 58 out of the 70 birthing hospitals in this state are participating or have participated in at least one of the GaPQC maternal initiatives. The hemorrhage bundle was our first AIM bundle that we participated in. It is now in sustainability, but data collection is still happening in some elements. And this is SMM data where we can just see generally just for ease, green is good. Right? Like green means that there has been some improvement for the hospitals that participated. So the top line over the years, GaPQC overall has seen a 9.2% improvement or reduction in SMM. Should have mentioned that this is SMM without transfusion here. We've had an improvement with our Black birthing patients, 11.2%, and then our rural hospitals have really met the goal, which was a 20% reduction. So hats off to them. We heard from Dr. Kramer this morning about seeking to understand disparity a little bit better and improvement and where those gaps really are. So what you see here is SMM broken down by race ethnicity, 2017 as a relative baseline, 2021 as kind of our most recent summative understanding of what that SMM is. And then that third column is the absolute, this column here is the absolute increase or decrease. And what's interesting, much like what Dr. Kramer mentioned, our non-Hispanic white patients over that time actually did see an absolute increase to the SMM without excluding blood transfusion. Our non-Hispanic Black patients saw an absolute decrease. Hispanic patients saw an increase, and then others saw an improvement. And taken together, this has helped close our disparity gap a little bit when it comes to SMM, excluding blood transfusion, in patients who experience hemorrhage. So as I mentioned, this is in sustainability now. We have seen improvements overall in Black birthing patients and in our rural hospitals. We've had some improvement in a reduction in our disparities. And now our job is to sustain these gains and do the best that we can to keep moving along and improving yet further. Hypertension is an active initiative that we have. Here are our structure measures. And if for all of our structure measures, higher is better. It means that that place has achieved that particular measure. And you can see over these data go through pretty much the end of 2022. And you can see our goal was to get to 80%. We've accomplished that for a couple of our measures, and then a couple of them still lag, like multidisciplinary case reviews. And I'm sorry, I can't find this one, and debriefs. Is that true? No, it's patient, family, staff support. That's the one. So we still have some opportunity. We want to get all of those above 80%. Our process measures also continue to have some real successes and some heading in the right direction, because up is better. But yet there are a couple of areas that we really do need to continue to work on. I'll highlight time to treatment. This guy right here is, from what we've heard across the country and other PQCs that are doing this bundle, this is the hard one. This is an important one. And this is probably an area that we'll want to continue to work towards. You know, we also have to acknowledge kind of throughout these timelines, the realities of things that happened here and with the pandemic. And we're not alone in having that experience. I know folks who are working in hospitals feel this every day. Things have changed with needing to prioritize, with staffing, with all of these things. But as we're recovering, hopefully some of these numbers will recover as well. These are similar to the hemorrhage. This is SMM among hypertension patients, excluding transfusion. Same concept. Green shows an improvement. Yellow shows an unimprovement or a non-improvement or heading in the wrong direction. And here you can see that overall, we have some improvement, not yet meeting our goals. Amongst Black birthing patients, there's been some variety over the years about improvement or not. And then rural hospitals have generally tended in an improvement direction. Looking again at the absolute increase and decrease, and then the percent change in disparities, we can see that there has been absolute improvement among non-Hispanic white, non-Hispanic Black, and Hispanic individuals, an increase in, increase in other. But our change in disparities, because the improvement is happening differentially across these classes, our disparities persist. Want to take a little bit, because that sounds, I want to look at this over a timeline, because as a quality improvement initiative, we can say, hey, if we have successes over time, quarter after quarter, we may actually be heading in the right direction, and we're just getting a snapshot that maybe continues to bring the pandemic into things. So this is SMM overall for GaPQC. And again, we are heading these last couple of quarters in a better direction. Looking amongst rural hospitals, we have our baseline here, our goal line here, and our rural hospitals have been meeting goal over the past several quarters. And then this is looking specifically amongst Black birthing patients. And there was really an increase here, but hopefully we're starting to recover, and we'll start seeing that in some of our other numbers. So key points for hypertension. We've had some improvements, particularly in the rural hospitals. We continue to need to work on this to improve health equity and reduce disparities. Over the course of this year, we're going to have conversations about what we need to do with hypertension, if it's ready for sustainability, if it needs some additional resources. We have improvement advisors who are working with hospitals now to try to figure out what individual hospitals need to kind of help this initiative. And we'll have questions about if we're ready for sustainability. I want to share a little bit of data from the most recent MMRC report. This information shows what pregnancy-related mortality ratio has been in Georgia over the past, well, these are the most recent years that are available. Our mortality data always lag a while because you have to wait for the whole year to be done before you can even really start assessing what has happened. But what we see from this analysis is that pregnancy-related deaths among non-Hispanic Black women was 48.6, and it was 22.7 for non-Hispanic white women. These are the leading causes of pregnancy-related deaths during that time period. Hemorrhage leads. Mental health conditions over the past several years has been making its way up, if you will. We're going to talk more about our cardiac initiative. So cardiomyopathy and cardiovascular coronary conditions, both independently are in the top 5, and then taken together certainly would be the top 1. And then embolism and preeclampsia round out. Importantly, when the MMRC reviews these data, they also look at every single death to a person who was pregnant or was pregnant within the past year, assigns a reason for the death, but they also try to ascertain whether or not the death was preventable. And so they identified, and we just showed you all of the deaths. So how many is that? 60, 70 deaths. They assessed that all of the pregnancy-related deaths that were due to hemorrhage, the mental health conditions, both of the cardiac buckets, and preeclampsia, eclampsia, every single one of those was preventable. So this is our charge, that we can do this, and by doing this work, we may be able to save some of these lives. They also thought that about 83% of the embolism deaths were preventable as well. Not all deaths happen while a person is pregnant. Certainly about 2/3 of them happen during pregnancy or in those first 6 weeks after pregnancy, and then the rest of them can happen up to a year after the pregnancy has ended. This is an infographic about the funder of the payer who supports the individual. And it's 68% of the individuals who had a death after delivery had Medicaid funding. So this is an important finding and a really great opportunity now for us, thinking about 12-month extension of Medicaid postpartum. How can we leverage that coverage and this knowledge to create supports for people in that postpartum time period? Here are the MMRC recommendations that come directly from there. There's a lot of words on here, so I'm just going to highlight some of them. Extend Medicaid postpartum 1 year, but not just that coverage, extend the services, help us think more broadly about what postpartum is. And so it should be us, it should be the hospitals, it should be, as you saw earlier, kind of those deserts that we have, it should be the emergency rooms and the family medicine docs and the families, like everybody needs to kind of shift our thoughts about what postpartum is and not just be like, oh, baby's out. Because that's how it is. You all know that that's exactly how it is. So we're really trying to change that conversation. We just heard a great talk from Dr. Hirschberg about blood pressure check. So thinking innovatively about how to make that happen and make that happen. Educate patients and families on maternal urgent warning signs, which you're going to hear more about. Reproductive life planning and counseling and interconception care. I can't talk enough about that. Obviously, as a family planner, I'm going to talk a lot about that, but perhaps more importantly now than ever, with restrictive policies, we really do need to proactively help people be able to have the families that they want when they want them, particularly people who have underlying medical conditions. And then we really need to enhance our communication and coordination of care through the postpartum perinatal period. I'm grateful for these data. These are going to be the baseline of the cardiac conditions. So we have, these are provisional right now, but come from December or October of 2020 through June of 2022, looking at, these are the outcome measures that we'll be reporting going forward for the cardiac bundle. So we have overall SMM amongst cardiac condition individuals of 17%. And then you can see it broken down by race, ethnicity. In each one of these outcome measures, which will not be a surprise to any of you, there are disparities for each one of them. This is SMM excluding blood transfusions overall and then broken down. We're also asked to look at C-section rates. So NTSVs amongst people who have cardiac conditions, preterm birth rates amongst people who have cardiac conditions. We know that some of this is iatrogenic, and so to have a sense of what's happening there. And so that leads us to the cardiac conditions. Look at this bundle. I mean, and also, isn't that a great slide? Like super informative. You can read it. So it did that a little, I mean, it's ridiculous. Obviously, I'm not going to go through it line by line and word by word. But a couple of things that I want to highlight. Our SMART aim is by February 6th of 2026. So still 3 years from now, but given this, we're going to need it, which is National Wear Red Day. We want to reduce harm related to existing and pregnancy-related cardiac conditions through the 4th trimester. So intentionality about that SMART aim by 20%. And so, as is always with the AIM initiatives, they get broken down into readiness, recognition, and prevention, response, reporting, and respectful, equitable, supportive care. And there are a bunch of different interventions for each one of those buckets. Readiness has been a space where we have been spending time and helping think through how we can also support hospitals, providers, and patients and families as we continue to roll out this bundle. The enormity of the bundle is just real, right? Like a cardiac condition is not a singular thing. It can look in a lot of different ways. It can have a lot of different impacts on the physiology of pregnancy and postpartum individuals. And as we've kind of talked about already, it can also involve a bunch of people. So your L&D people, your outpatient people, your postpartum people, your anesthesia people, your cardiology people, your sometimes maybe surgery people, all the people need to be involved in this. But I think it's a real opportunity for us to shine, because Georgia's one of the first states after, California was the first, but one of the first states who's implementing this cardiac bundle. We have a lot of opportunity to shine. We also have a lot of need. Right? Like we know our patients need this. So here we go. And here's what we've been up to. This is a different type of bundle, one, because it is big, but it's the first time that for maternal arms that we are doing waves. So we have 12 hospitals within 8 health systems that you see here that are participating in wave 1, that are actively participating, that will be not only trying to implement the bundles in their settings, but also submitting data and following things up in that manner. We are opening and have opened up the learning community to every hospital and individual person who wants to learn, come and learn. But this wave 1, these are the folks who are submitting data. And so, just huge thank you for joining us and partnering, because we're going to learn a lot and hopefully help those hospitals that are not yet able to participate. And this has been our work group. Can you handle that? So there have been a lot of folks who have been looking at that bundle and thinking about how do we put legs on this? So we have OBGYNs, maternal fetal medicine, midwives, cardiology, anesthesia, emergency medicine, family medicine, and educational experts. I hope we got them all because it's possible that we missed some, but thank you if your name is on this list. We appreciate you. In addition to having a large work group, we also have several small work groups who have been working on products that can be used by anybody who is trying to get this done. So over the past year and a half, we have been led by Dr. Iris Krishna and a bunch of MFMs from Emory have put together an educational series primarily aimed at the clinical folks about different cardiac elements. These have all been recorded. So they were our traditional monthly educational session. They're recorded and now on a YouTube playlist on GaPQC's website. So if you didn't have a chance to attend live, or you just want to review, or you want to share it with colleagues, those are out there and available. This is gorgeous. And is a baby of Dr. Teresa Bird, who thought that it was really important to have a quick reference guide for how to manage kind of in the moment a cardiac issue. So you have a person who comes in, maybe they're new to you or, just traveling through and happens to come to your hospital and you have a real issue and you need to remember, is this a person that needs to be dry? Is this a person who needs extra fluids? Is this a person who needs to have a C-section and can't push a baby out, right? Like I need to know those things and have that kind of on the ready. So this is a fourfold, like it has a bunch of different conditions like heart failure, cardiomyopathy, I can't even read some of those things, but different conditions that there's a sample out front. The vision is for it to be folded, to maybe be put on a poster. I invite you to take a look at the prototypes that are out front. Think about how you or your team might use this best and give us that feedback. How would you like to use it? Like what might be better? Where else should it be? If you are a cardiologist, if you're married to a cardiologist, if you know a cardiologist who wants to just give a stamp of approval to this, because there have been a lot of really smart eyeballs on this, but it would be great to have one that is really in on cardiology. And we'll give you Teresa Bird's cell phone so that they can call her immediately so that we can get this off. Another product that we've been working on, again, Dr. Bird and then Dr. Schulman from Northeast Georgia, have been thinking about how to kind of modify a little bit the CMQC's maternal cardiac warning signs. And so we have two different drafts, again, for you to take a look at, give us feedback on, think about how you might want to use these. The red are the urgent. This is a severe problem. It's red to encourage you to stop and stop and pay attention. And then the yellow is a little bit more mild of let me understand how to manage you and what to do. So we have this draft, and then this is similar information, just with a different look, different vibe. And again, thinking through, are these laminated cards that, are hung? Are they a badge buddy? How do you want to use this? And then, because we know that the postpartum time period is super important in helping people remember that we want to educate our patients and that we want to have patients have this information. We've had some medical students who are basically, let's call you guys doctors because you're minutes away from it. Soon to be doctor patients Timmy and soon to be Dr. Olivia Van Benchoten have been working on this project to think about how we get information to patients. Somebody who's brilliant, I don't know who, came up with the peach mnemonic. So thinking, how do we make this Georgia? If you are the person who came up with the mnemonic, please raise your hand so I can give you appropriate credit. Okay, and then Olivia and Patience, they should raise their hands because I don't think I made you raise your hands before. There you go. So thank you. And then, so PEACH stands for palpitations, edema, abnormal breathing, chest pains, high blood pressure. Several different kind of looks and thoughts about this, but specific information to say, you know, hey, I'm having these symptoms and I had a baby within the past year. So to kind of have some intentionality about sharing that specific part of the information. And then there are different prototypes that we're asking for your feedback on right now, but they could become little wallet cards, could become magnets, could become flyers, who knows what they could become. And then finally, if you guys have a QR code scanner, please snap this. We would really sincerely appreciate your feedback on these products because ultimately you're all the people who are going to be using them. So there are not very many questions, super quick, but we definitely want your feedback. And again, the kind of tangibles that you can play with are out in the hallway. I think that's all I've got. Dr. Patel, I believe, is going to do his Neo update virtually. All right, I'm going to sit down.
Good afternoon to all of you attending the GaPQC annual meeting.
I mean, he needs an introduction. He needs no introduction to me or many of you, but some of you need an introduction. Ravi Patel is a neonatologist at Children's Healthcare of Atlanta. He's an associate professor of pediatrics at Emory University School of Medicine. He received his medical degree from MCG at Augusta University, and then obtained his Master of Science in Clinical Research, as well as his fellowship training in neonatology at Emory. He also spent, I don't know how long, but he did quality improvement training at Cincinnati Children's, which is one of the preeminent facilities for QI, at least in general, in the country. His research interests include necrotizing enterocolitis, blood transfusion, and caffeine therapy. His clinical interests include clinical research and quality improvement. And as the current co-chair, neonatal co-chair, he will now become the neonatal chair. So his presentation.
Good afternoon to all of you attending the GaPQC annual meeting. I wish I could be there in person. I'm unfortunately traveling abroad, but I'm delighted at the opportunity to share what we have been working on in optimizing newborn nutrition as our neonatal initiative. As an introduction, my name is Ravi Patel. I'm the GaPQC neonatal co-chair. I'm also a neonatologist at Emory University in Children's Healthcare Atlanta. I do have a couple of disclosures, none related specifically to this talk. I serve on the Scientific Advisory Board of Noviome and on the Data Safety Monitoring Board of Infant Bacterial Therapeutics and Premier Research. So what I hope to do today is to go over these 5 objectives. First is to give you some idea of the motivation of how we got started with optimizing newborn nutrition and some of our baseline measures in terms of the context of where we were starting as we think about how well we are doing with newborn nutrition in Georgia. And then to transition from that to our overall framework for improvement in this initiative, and then give you an update on some of our key recent measures to date, and then where we hope to go over the next year and a half. When we think about how we got started with optimizing newborn nutrition, we've been part of the GaPQC for over a decade. And as we finished the last initiative, which was focused on neonatal abstinence syndrome or neonatal opioid withdrawal syndrome in partnership with the Burma Monoxide Network, we really started to think about where we could make the biggest impact on improving care for newborns in Georgia hospitals. And as we thought about that, we really thought there was this great opportunity to focus on newborn nutrition. And that's where we've been over the last year and a half, and where we look forward to continuing our work over the next year and a half through the end of next year. And at one of our prior meetings, we had Dr. Kristen Marks from the CDC who gave us a summary of our report card of how Georgia was doing. And this is part of the MPing survey that many of you who've been participating have heard that Claire Eden has mentioned and encouraged hospitals to participate in, where it really highlighted opportunities for Georgia to improve with newborn nutrition. And some of the things that Dr. Marks from the CDC highlighted, there are things that we were doing well in Georgia in terms of strengths, for example, glucose monitoring, post-discharge follow-up, and documentation of exclusive breastfeeding. But there were also areas where we had room for improvement, where less than 40% of Georgia hospitals have good responses for areas such as mother-infant separation for procedures, formula feeding of breastfed infants, and written policies and procedures. And I think these three areas, as I'll share later in this update, were really ingrained in terms of our initiative of wanting to move the needle on these aspects. And so we launched Optimizing Newborn Nutrition, and we did that with the model for improvement that really we engineered to be applicable to all hospitals that care for newborns, whether that's in the neonatal intensive care unit setting or in the well newborn setting. And we focused on kind of how we could improve on using the model for improvement. And we took a structure and a key driver diagram to really try to address what were the primary drivers that impacted key nutrition measures. And our overall GaPQC aim, when we started off, and this was our first version in July of last year, was to increase the percentage of newborns in GaPQC hospitals that had human milk as their first feeding. And I'll give you an updated SMART aim as it relates to this initiative. But as we initially designed this, and this key driver diagram has been updated, but I wanted to show where we started from, we really had a number of interventions that we were hoping to target. And we tied those to monthly webinars that we've been doing ongoing to give hospital teams change ideas and guidance on what should be aspects of ways they can improve newborn care as it relates to improving the use of human milk as a first feeding, as well as the timeliness of breastfeeding and formula supplementation. I'm going to share how we've been doing with those three measures as we've been collecting our baseline data. So we started with the first 3 months really of taking a framework of doing audits at hospitals to capture a snapshot of how we were doing. And we designed these audits really to let us know how are we doing in the last month, in the last 2 months, to give us measurement that hospitals could use to give a sense of where they were and whether they were actually improving. And so what I'm going to share is a collection of audits that hospitals have done and how they've done with these three key measures for the initiative. Now, our overall SMART aim for the GaPQC initiative is that we want to increase the percent of newborns in GaPQC hospitals with human milk as the first feeding from a baseline of 73% to 80%. So an overall 10% increase by September 1st of 2024. So here we are with our key measure. This is the overall SMART aim for the collaborative, and this is human milk as the first feeding. And again, these are based on audits that our hospitals are doing. We collate these across our participating hospitals. You can see we started off with a baseline and we looked at the first 3 months, 73%. Over time, we've had more hospitals that have increased. And so the number of hospitals that have been reporting data have increased. But our goal by the end of September, so in about a year and a half, is to try to see if we can move this to at least 80% of hospitals where newborns are receiving human milk as the first feeding. We know this is challenging from work that other hospitals have done. These are difficult measures to move, but we really do think that we have a lot of opportunity to increase this as we consider optimizing newborn nutrition for our hospitals in Georgia. One of our second key measures has been formula supplementation the last week. You recall from our CDC report card that we had really a lot of room. And when we look at our baseline measures, about half of newborns are receiving formula supplementation within our participating hospitals. And we think that we have room to decrease that through a number of different opportunities that we've discussed. And the last key measure has been the timeliness of breastfeeding and expression within 6 hours of birth, where our baseline is about 51%. So about half of newborns in our hospitals have a timely breastfeeding expression, and we think that's room for improvement. And with this, we've even seen some suggestions, if we look at just the number of points above our baseline measure, where we've started to potentially even see improvements in this measure just over the last several months when we consider our baseline period. Now, in addition to these measures, which are looking at how we're doing month to month, we also want to get a sense of how we're doing with structural measures of policies to implement potential changes. And as I shared earlier with our CDC MP report card, we had opportunity to improve on policies. And so we started, when we began this initiative, a baseline audit of the structure of where hospitals stood with policies. And we've been doing these every 6 months. And we just finished our January audit. And it gives you a sense of where hospitals have been moving in terms of some of these key policies. One of the goals is to give change ideas to help hospitals implement changes. And one of the ways to do that is to do policies. And so you can see we've gotten to darker green and we've moved upwards in many of these key policies. For example, policy supporting routine newborn care has really improved, as well as skin-to-skin care and early lactation. So we hope to see these sustained. And the hospitals, the number of reporting have changed a little bit over these periods, but this is a marker of how we are doing over time in some of these policy measures. And you can see these graphically where we've seen changes in the direction we would like to see over these audits. And we'll continue to do this over the next periods every 6 months to try to see if we're making progress on the policies. 2 areas that we have room still to improve are on policies on hand expression of milk and on donor milk use, where we think we can have some improvements. Now, I'm also excited to really see how engaged our hospitals and our teams are in this initiative. And so just some of those measures to give you a sense of how engaged we are with optimizing newborn nutrition from hospitals in Georgia, and what really the work of many of the committee members and hospitals have been doing. We've had 11 webinars since we began this initiative and launched in April of last year. And we've had over 47 hospitals having at least some participants joining these webinars. So a lot of interest and engagement and learning across these different webinars from hospitals in Georgia. And when we think about improvement and active engagement, we've had 39 hospital sites that have been part of active improvement. So those are sites that have joined up to actually do more than learning and improve. And as part of this active improvement, we've had 701 staff in these hospitals that have completed micro lessons, educational lessons that are small modules for really high impact learning for improvement as it relates to optimizing newborn nutrition. We're going to continue to launch and roll those out over the next year and a half. And finally, we've had 2,530 infants that have been audited. That's really been critical data that gives us a sense of how we're doing, and we give this back to you in reports every quarter to give a sense of how you're doing in your hospitals. And we hope that this really is the tool that you can use to guide your improvement. And 28 sites on average have been submitting data every month, and we've seen this improve over time. So we really thank our sites and those that are doing the work to collect this data and submit it. We know this is a lot of effort. We try to be as minimal as possible in terms of the key data points that can give us a sense of how we're doing and how we can improve. And this is a nice snapshot of really how we've improved our hospital completion rates from audits from about 73 to 77% when we first started, now closer to 90% for most of our months. So thank you again to all the hospitals and the data abstractors for doing these audits that give us a sense of how we're doing. And this is really critical because quality improvement needs data. If we ask ourselves the question, how will we know if the change results in improvement? We really need data to measure to see if we're improving both as an overall collaborative, but also as hospitals. And so this is really critical. And so thank you for that. Now, finally, moving forward, spent a lot and accomplished a lot over the last year and a half. We started with our overall key driver diagrams. We worked on establishing some baseline measures. We got some structural measures on policies that we audited early in last year. And then we worked on doing audits to get a sense of where hospitals stand in baseline measures. Many of our hospitals have developed specific smartings, most of them tying to those 3 measures I shared, but some that are beyond those 3 measures. And really what we want to now do is to try to make changes to lead to improvement. And so a lot of our focus now as we move forward over the next half of the year, as well as into next year, is really to think about changes and how we can make changes to lead to improvement. We have a good sense, and as part of the audits and the reports you've received, you have a good sense of where you stand in those measures. You've developed SMART aims, and some of you have developed key driver diagrams, and we hope to build on those key driver diagrams. And really now we want to try to implement some of those change ideas and some of those interventions into your sites to test them out to see if they'll work. And then to implement those that work and then to solidify them into policies, and really with the ultimate goal to move the needle on some of these measures that we've been working on. We know these are challenging. People have been working on improving some of these measures for many years, but we hope that overall, as we can learn and work together, that we can really move the needle on this. So I wanted to finish really by thanking all of you that have been participating, and really the motivation for this is we really want to improve the care we provide for newborns and their families in our hospitals in Georgia. And we think this is a great opportunity to do this together. But I also really wanted to thank our Neonatal committee, Neonatal co-chair Dr. David Levine, as well as Claire Eden and Dr. Taryn Fairley, who've really been the experts to help with driving a lot of our content, and the rest of our committee. And most of all, I wanted to thank our leadership at the GaPQC committee in particular, who've really been instrumental in keeping us organized and helping move things along. So I wish I could be there in person, but I am excited by the work that everybody's done, and really even more excited to see where this goes over the next year and a half. So thank you for the opportunity for the update.